Good morning, Dr. Rosensweet.
Good morning, Carolyn Shapiro.
That would be me. How you doing?
Good.
Nice. Okie dokie. So here we go with our questions and with the most wonderful person to answer them. And thank you very much. Welcome to you, the ladies, the men, the new women, the women who have been with us all along. Welcome to everybody. I have some questions here. My 1 and 2 question, they're going to kind of blend together, and I know you're going to understand this, so I'm just going to go ahead and ask it. You ready?
Yeah.
All right. Okay. So, woman writes in, when a woman gets to what is called optimal levels with her hormones, can that optimal level change, or does it always stay the same? Now, I'm moving into the second question, which says, what does optimal mean anyway? And if a woman, well, I'll get to that in a minute. What does optimal mean anyway? That's the question. When a woman gets to what is called optimal levels with her hormones, can that optimal level change, or does it always stay the same? And then, what does optimal mean anyway? Uh-oh. Are you there? Not sure if you can hear me, Dr. Rosensweet. Oh, I see me. So, hello, ladies. Dr. Rosensweet will be back in a minute, I'm pretty sure. In the meantime, you can look at me and my lovely backdrop, and we will get our answers in a second, I believe. Hang tight. Hang on, let me see if I can find him.
Restart. And hopefully we're on. Let's see. Can you hear me, Carolyn?
I can.
All right. So why don't you continue? I think we're back. I think we're back at it.
Well, we've only been doing this 20 million years or something like that. Would you like me to re-ask the question?
Yes, please. Yes, please do.
Okay. The woman writes in, when a woman gets to what is called optimal levels with her hormones, can that optimal level change or does it always stay the same? And what does optimal mean anyway?
Excellent. Excellent question. Well, we know the range for optimal levels for a 20 to 29-year-old, for example. And women vary enormously as to how much estrogen they need to menstruate, what their progesterone looks like when they actually ovulate, because if they don't ovulate, they've got very low levels of progesterone. If they ovulate, they get very robust levels of progesterone. What the optimal zone is for a woman with testosterone, what constitutes too low testosterone, and which, if her testosterone drops too low and she's 20 to 29-year-old, she's going to lose her muscles and all the other adverse effects that takes place mood-wise, bone-wise, from too low testosterone. And we also know the optimal zone for DHEA for a 20 to 29-year-old. And, as you move up in decades, and this is how labs report them, 30 to 39-year-old, well, they're not as robust. They've, once again, a woman's highest levels of all these hormones coming out of the ovary, they're highest at age 20, plus or minus 2 years. And then they gradually decline. So as you move into how laboratory ordinarily report these, according to decade, you get into the 30 to 39-year-old, it's less. 40 to 49-year-old is less. And then somewhere in there's a cascade low as the woman loses her ovarian hormone output. What's optimal? Well, we know, for example, let me just take the estrogen family. We know a 20 to 29-year-old has a certain range. Some women, they need this much, so to speak, to menstruate and to feel good. Other women, they need this much. So there's a range there. And that range is quite dramatically different. But all of it is optimal for a 20 to 29-year-old. What's optimal for a woman who's no longer menstruating? We know that number. We know those numbers. In fact, they're right below the range of estrogens. And I'm talking about estrogens again, for a 20 to 29-year-old. If this is what a young woman, the range that is optimal for a young woman, 20 to 29-year-old, in that they're healthy, they're menstruating regularly, there's so much estrogens they need, it varies, this is the low amount, this is the high amount. What we think is optimal for a woman in menopause, estrogen-wise, is right below that. And there's a range there. And what's the bottom line of that range? That she protects her bones in her vagina. She has sufficient estrogen to protect her bones in her vagina. And what's at the upper limit of that range? That she does not stimulate breast glandular tissue to proliferate. Because a young woman, even the young woman who has optimal estrogen level is at the lower end here, still once a month, she has enough estrogen to form an endometrial lining that she can menstruate. And simultaneously, at that level, she's going to have enough estrogen to do what a young woman does. Once a month, she prepares for breastfeeding. Whoa, really? Yeah, once a month, she not only has enough estrogen to form an endometrial lining and menstruate, she has enough estrogen to do lots of other things. And one of the other things that she does once a month is she prepares her breast as if she's going to get pregnant and breastfeed. So she gets breast glandular cell proliferation once a month. And a woman usually can feel that, in that her breasts get fuller, sometimes even tender. And then, should it be that she does not get pregnant, once a month, those estrogen levels drop really low and she menstruates at the end of the month. And her breast glandular cells actually undergo deproliferation. And her breasts get smaller once a month, every month. Wow, it's staggering. The orchestration of it all, the design of it all. It's just, you want to believe in the divine, study the female menstrual cycle, as I have said many times. It's so staggeringly amazing. Well, in a woman who's in menopause, we don't want once a month breast glandular cell proliferation. It's very different when you have a 50-year-old and her immune system. We don't want the mutation, the cell division that takes place when we casually talk about breast glandular cell proliferation. Yeah, we're talking about mitosis. We're talking about cell division. It's a different thing in a 20-year-old immune system capable of picking up a mutation and apoptosing it, getting rid of those cells that were the result of a mutation. The 50-year-old, okay, hopefully their immune system is strong enough to pick up these aberrant cells that have resulted from mutation and getting rid of them through apoptosis. Yet, a 50-year-old immune system is not as vigorous. What did we learn from COVID? That the older folks don't do as well. Their immune system isn't, in general, I'm not saying universally, but in general, the older folks' immune system is not quite capable of doing a great a job of taking in that COVID and spitting it out, getting rid of it, because the immune system knows how to do those things. It's the elderly that are more vulnerable to not having the robust immune system of a young person. So, when I say that a 20 to 29-year-old has this range that's optimal for estrogen, and I'm saying that a menopausal woman, she doesn't need that much. She can have a healthy vagina. She don't want to drop too low, or that vagina is not going to be healthy. She doesn't want to drop too low, or bones are not going to be healthy. But we know what that number is, and where do we know it? On 24-hour urine hormone testing only. Because yours truly went into the medical literature and looked at the studies that were done and was able to define for a menopausal woman what's too little. We don't want to drop below 8 micrograms of total potent estrogens, for example, per 24 hours. We don't want to drop below that, or her vagina is going to be vulnerable to a vaginal atrophy. Don't want that. And don't want, it's fun to watch your face.
Not a pleasant experience for me.
Yeah, this stuff is very up close and personal to you.
Yeah.
And we don't want the bones. We don't want to be losing bones. So we know what that lower number is. And at the same time, we don't want to go above the upper number, because we're going to get breast glandular cell proliferation, and a menopausal woman just doesn't need that. So that's the range I'm talking about, the optimal range for a woman in menopause. I define it out of the medical literature. And really, the parameters are not too low that you get vaginal atrophy or bone loss, and not too high. We want a healthy vagina. That's why we're defining that lower number. We want a healthy vagina. And not too high that a woman gets breast glandular cell proliferation. That's the optimal zone for estrogen. And I could tell a similar story for testosterone. We want enough testosterone, I'll tell you.
Well,
in fact, it's more like a 20 to 29-year-old we're aiming for. We want muscle health. We don't want you to lose your muscle in a process called sarcopenia. We want libido health. We want mood health. It goes for all these hormones.
You know, there's a story that you tell that I always like to hear, and it's when I first saw you on YouTube like years ago, and you were talking about being a doctor and doing your rounds and having your long coat, and you were so excited and everything, and in the hospital, and then the doctor said, "Now we have class," and you're like, "Ugh."
Yeah, we had lectures at the University of Michigan for the senior medical students. They took place in the hospital, and we had a lecture by a gerontologist. And a gerontologist said, and thanks for reminding me of this because I love this story
I
too.
love this
And
story.
I'm sitting there in that lecture thinking, I'm a young guy. What do I want to hear about old people? Well, now I am an old people.
Apparently, so am I. Just found
So
out.
all this stuff is very relevant to me now. But there I was, 28, listening to a quote gerontologist, but that gerontologist caught my attention, I want to tell you. And that gerontologist said, "You're senior medical students. You know thousands of diagnoses. Let me tell you what's really happening to old people. They're losing their muscle by something we name sarcopenia, but what's happening, they're losing their muscle. And what happens when they lose their muscle? They get unstable in their gait, in their ability to walk with stability, in their ability to stand with stability. And you get sarcopenia and you lose that muscle, and you get vulnerable to falling. And the older people, this is the second thing that's happening to them. They're falling on these osteoporotic bones. They're going to fracture their hip. And back there in 1968, where orthopedic surgery wasn't as terrific as it is today, they died. A lot of them, not all of them. They fractured their hip. They died. And even nowadays, yes, you can get an artificial hip, but you're going to wind up in a year or so, even if you have that fantastic operations that they can do. Most of these folks are going to wind up, even though they've had the operation, they're going to die within a year. Yeah, not everybody, but a lot are.
Well,
So,
a question did come up, if you don't mind. Two of them. One is I had my testosterone checked out. My free testosterone was too high, 14.0. Excuse me. And my total testosterone was 177, which was okay according to my PA. For this reason, I believe my PA lowered my testosterone. I don't know exactly what that question is because it says my question is what. But then she says, what is testosterone free? And is this a reason to lower it?
okay, well, I'll go there, but
Okay.
I still want to continue with the excellence of this first question.
Okay.
What's the optimal zones? So the optimal zones for estrogen, if this is a 20 to 29-year-old, the optimal zone for estrogen is a little below that, enough to preserve the vagina and the bones, while not too high as to promote breast glandular cell proliferation. Testosterone is more like a youthful level. Progesterone, it's as rich as we can get it. Approaching youthful levels. And the same with DHEA. We want to get those DHEA in reasonable youthful levels. Now, there is an exception for optimal with estrogen. It's enough of an exception that I do want to mention it. There's some women that they're starting to get cognitive changes. Oh, a euphemism, senior moment. Yeah, senior moment. They're not thinking as clearly and they're not remembering as clearly. And some women and men, but in this case we're talking about women, that cognitive challenge can really be life disruptive. Here you got professional women or women who are navigating in their community and in their household, and they're not thinking clearly. In fact, it's well known in the medical literature that sometimes this is trending towards dementia, where the cognitive challenge is so severe that it's really life disruptive. And my mother had this, so I know it really well. Yeah, that loss is really significant, and it can even trend towards something as severe as what's known as Alzheimer's, but it's really a form of dementia, and that's a complex subject. So there are exceptions where women, if you replenish their estrogen adequately, that quote tendency towards cognitive challenge / dementia disappears. So I want to tell you the story of a wonderful colleague, a medical doctor. I met her when she was 65. She happened to be testifying in the same panel that I was at the National Academy of Science. I say the National Academy of Science because I'm very concerned about the National Academy of Science. It's so different than what I had always hoped it was. It's not what it, to me, in my experience, when they formed the committee to examine the safety and efficacy of compounded bioidentical hormones, it was not what I wanted to see. In other words, it didn't have scientific integrity. Woo! And it made these proclamations and these declarations in its report that were so different than the integrity of science that I'm used to. For example, on that committee, they're examining the safety and efficacy of compounded bioidenticals. There was no physicians on that committee who would prescribe compounded bioidentical hormones. And there was no pharmacists. There was no compounding pharmacists that this is their life work. There was no compounding pharmacists on that committee. Well, the ulterior motives of this committee are very appalling and egregious, and I'm not going to go into that today. I took a sidetrack there, but this is very important because we want to mobilize women to go to the websites wethewomen.us or CBHRT coalition.org or the APC compounding.com, because the right for a woman to choose and the right for a healthcare provider to prescribe compounded bioidenticals is really under great threat. So women, that's why I'm taking the sidetrack. But really, I took the sidetrack to remember I had done some research on the physicians who were going to be on the same panel that I was on. And I learned about one of the physicians was on a very high dose protocol of taking estrogen. And I knew that that was a bugaboo for the committee because they had telegraphed that to me when they were doing their initial interview to decide whether they wanted to have me there or not. And that high dose protocol was one of their bugaboos, and they wanted to know what I thought about it. And I told them I was not a fan of it. But you never say never in medicine. So I want to tell you the story about this physician, bless her heart. We're on coffee break, and our panel is now organizing to sit in front of the general committee, the National Academy Committee, and she's about to sit down. I'm already prepared. I'm already sitting there, and she's introducing herself to me, and I introduced myself to her, and I looked up at her, and I said, "Are you going to tell them that you're on that high-dose estrogen protocol?" And she winked at me and said, "No," because she knew it was a bugaboo there as well. So she and I went out to lunch with her son. The three of us were sitting there at lunch. This is after our panel had testified. And she's 65 years old, and she tells me this story. When she was 55, she went into menopause, and she'd already been in menopause, and she started to get cognitive decline. She started not thinking clearly. And she says to me, there I am, I'm sitting in my office, my medical office, I'm interviewing my patients, consulting with them, and I'm not thinking clearly and I'm not remembering things. And it was really starting to bother me. And I was looking down the barrel. This is not a metaphor I like to use, but this is a metaphor that really applied to her. And she said, my mom had dementia. And my mom's sister, my aunt, had dementia. And here I am, 55 years old, and I'm sitting in my medical office, and I'm not remembering some very important details about my patients. And it got worse and worse, and I started to be concerned that I was going to have to stop my medical practice because I couldn't manage it anymore. And she said, but I knew about estrogen, and I started taking estrogen topically, started applying it to my skin. I went to a compounded bioidentical pharmacy, and the pharmacist made up some bias for me, and I started taking it. And wow, my mind started clearing up. And she said, I took a little more, and I got a little clearer, and I started taking more until I kept on taking more until I really got clear. And I got clear, and my period returned.
Thanks.
So obviously, she was on a robust dose of estrogen. And for the protocol, it takes 3 to 8 times the amount of estrogen for a 20 to 29-year-old to really get that period to restore in a woman who's no longer having her period, or to get a woman's period to sustain. 3 to 8 times the upper limit of normal of a young 20 to 29-year-old menstruating. How do I know that? Because I've tested women on this protocol, and I've done 24-hour urines on them, and they feel good. Or in this case, they've gotten their period back. If that's what it takes to get your period back or to keep a period going, 3 to 8 times the upper limit of normal of a young person. In medicine, it's always a risk-benefit analysis. It's always, you can't make laws about every single woman. And in this case, I'm sitting there, I'm listening to my colleague who I just had so much appreciation for, and she's clear as a bell as we're having lunch at age 65. And she's still having her period, and she's on estrogen levels that I knew were supercharged. But for her to get her cognition back, so you never say never in medicine. It's always a risk-benefit analysis. And in order for her to think clearly, she needed to get her period back. She needed to have her estrogen levels that high. Well, this is well known in the medical literature. Although the medical literature very clearly defines the amount of estrogens needed to protect the bones in the vagina. This is young 20 to 29-year-old. They're quite lower. They're sitting at the low end there, and they're even less than the amount needed to menstruate. But the medical literature says you can't make the same assumption for cognition. Sometimes there's some women who require really robust levels to get their thinking back. And the medical literature knows that, and the medical literature gives, the medical studies have demonstrated that level can be such higher. Well, your original question posed by that questionnaire, that was a brilliant question. How much does it take? What is the optimal zone? Well, for most young women, 20 to 29, it varies woman to woman. Some don't need as much as others. In fact, this can be 3 times higher than the lower limit for some women. But for menopausal women, the medical literature tells us to protect the bones, we need this much. It's less than a 20 to 29-year-old. But there's exceptions. So what's optimal? That's a moving target there, Carolyn Shapiro. As you and I have discussed many times.
Many times.
Some women who really need robust levels of estrogen to function normally with their brain. And God bless us all. You know, what is it?
Absolutely.
Yeah. And are those women at risk? Not necessarily. In general, women who are even on Premin or Prempro, horse urine-derived estrogen, and Prempro has this artificial progestin in it that's problematic. Those women are at less risk for breast cancer, heart attack, and stroke than women who are not being treated with estrogen. So just to keep things in perspective. So optimal, to return to the question, there's a lot of moving parts there. And when there are that many moving parts, how do we evaluate those moving parts? Well, in the case of cognitive decline, the endpoint is, can you get your brain back? Now, there's other things that can relate to dementia. There's an amazing medical doctor who I think has done the best work in dementia. His name is Dale Bredesen. He's written a book on the end of Alzheimer's. It's a complex subject. There's a lot of moving parts. Hormones is one of them, and women, hormones is one of the most common issues. So we really pay attention to estrogens in hormones in a woman who's menopausal, who's got cognitive declines, and like I said, we'll push it. So what's optimal? Well, it depends on the woman. And that's the story of menopause. It's an individual thing. And there's many moving parts, and we examine the details of the moving parts in every single woman. That's how we do it. It's not a problem at all. It's not a problem. You just, and so many physicians and nurse practitioners and people who are on the front lines and physicians' assistants who are treating patients of all ages. It's an individual thing. And there's many moving parts. So what? That's what we study. That's what our profession's about. That's what specializing is about. Oh, specialization. Yeah, it does take focusing in and getting good at hormones.
Yeah, and passion. Yeah, passion.
It takes specialization. And that's the great news, because so much is known. That's why I gravitated to, I was a holistic doctor. I was treating people with all kinds of diagnoses, and I made a decision about 25 years ago. I got to narrow this down. I got to specialize in one thing. The knowledge bases are so big, and that's the good news. The knowledge bases and the experience bases are so big, so we recommend that you specialize. So the question again is an optimal. What's optimal? Well, it depends on the woman. It depends on the man when we're treating men. It depends on the individual. And there's many ways that we evaluate that. We evaluate it by symptom alleviation. When you go on to hormones, you're usually going on them because you're having 75% of women in menopause are having symptoms. So one of the parameters of what's optimal is, are we alleviating your symptoms? Are you sleeping again? Is your mood good again? Are you thinking clearly? Is your vagina healthy? Is your libido returning? How are your bones doing? How's your breast health? So as I mentioned these various topics, there's various tools we use to define what optimal is. So once we're treating a woman, the tools we use is we have an extensive questionnaire that relates to symptoms. And by golly, by gosh.
May I quote you?
Yes.
Thank you.
I think it's a medical term, I'm pretty sure. By golly,
No.
From a woman's perspective, she's going to want to have those symptoms alleviated. She's going to want to feel good again.
And how? Oh, yes.
And how. So that's one of the parameters we use to evaluate an individual. Another parameter we use is the 24-hour urine hormone test, because we know a lot about what's too much and what's too little.
And God bless that you do both.
Also want to do mammograms. I'd like to say that thermograms can do it, but they don't. They have false negatives. They're valuable for other things. Breast thermography is valuable to assess in a woman who has increased breast density on mammogram. Does she have inflammation? Because thermograms will pick up increased heat, but thermograms are absolutely not adequate to evaluate for cancer. So forget about it. Yes, you'd like it to be so. So did I. In 2000, I thought, hey, this is great. Don't have to put a woman through radiation. Wrong. Mammograms do pick up, not perfectly, but they're great for assessing, is there risk for breast cancer there.
Well, I'm very grateful I had my mammogram, 11 years in, having had them for 11 years. Very grateful.
Yeah, very
Yep,
important. And then
absolutely.
thermography is another tool we use to assess for inflammation, but we don't use thermography to evaluate risk for breast cancer. No, it misses. It has false negatives. So that's very important. We use bone density tests to,
Mm-hmm.
yeah, a woman's getting symptom alleviation. A woman's got good 24-hour urines. We know what the optimal zone is. Speaking of optimal zone and 24-hour urine. But the bottom line is, if she's at the low end of that optimal zone, we're going to want to know what that bone density test is because we don't want her to be losing bone. There's another test that we can test a woman's urine to see if she's losing bone. There's other parameters that we want to test. Sometimes we want to assess if a woman's spotting. We want to see, yeah, well, what does her endometrial lining look like on transvaginal ultrasound? This is the realm of the gynecologist.
Yes.
So there's many different things we use to assess optimal. And that was the question you asked, or the questioner asked. And that's the answer. There's it's a longer, what is it, a 37-minute answer? Because
It's a
there's a lot
Dr.
of
Russell
things
sweet
that define
answer.
it. Define it. It's a lot of things that define it. And I can summarize them. There's symptom alleviation that defines optimal. There's 24-hour urine hormone test that defines optimal. There's bone density tests. There's mammograms that define it. Sometimes thermograms in addition. Sometimes there's transvaginal ultrasound. And there's some blood tests because we want to see that a sex hormone binding is normal at least.
Yes,
That's
exactly.
the parameters of what constitute optimal. All of them.
Yeah, that word optimal for many is very confusing. It certainly was for me some years back. I had not a clue. Um,
What optimal mean is what's the right amount. What's not optimal is too much or too little. We can use symptoms, but that's not enough.
right.
So, for example, when a woman says to me, wow, I was having symptoms royale, life stopping stuff, and now all my symptoms are gone. I'm sleeping well. I'm not waking up in the middle of the night with a hot flash. My brain's cleared up. I feel good. Is that enough? No. For example, one year I did a study of the women that I had 24-hour urines on of the preceding year. And what I used as my criteria is the women said to me, I feel good. Okay, well, let's do a 24-hour urine hormone test on you. Only 25% of those women who said that they felt good, in other words, they had symptom alleviation, they thought they were on enough. Only 25% of them were in the optimal zone as defined by the medical literature. What protects the vagina, what protects the bones, what falls shy of breast glandular cell proliferation. Only 25% of those women, 1/4 of them, they felt good, they had symptom alleviation, but only 25% of them were in the optimal zone. 25% of them were on excessive estrogen levels that put them at risk for breast glandular cell proliferation. 50% of those women, they felt good. They did not have sufficient estrogen to protect their vagina and their bones. They were close, but nobody wants to be close over the long run as far as bones and vagina go. We want to be in the zone. So what does it say? Symptom alleviation is not sufficient. It is claimed by many folks who treat women in menopause that, hey, this is about symptoms. When a woman gets symptom alleviation, that's all you need. No, that is wrong. Symptom alleviation is great. And if women have symptom alleviation, they're going to be close. But yeah, you want to be close around your bones? You want to be close around your vagina? No. The answer is no. You want to be in the optimal zone. So anyone who tells you that symptom alleviation is sufficient and you don't have to test, that's not the person you want to be dealing with professionally. You want a person who knows how to assess you, and it's because it takes more. It takes at least 24-hour urine hormone testing to assess if you're really in the optimal zone. And it also takes bone mineral density, and it also takes mammogram. Those are the bottom lines to assess whether a woman's being properly treated. Clinical symptom alleviation, 24-hour urine hormone testing, bone mineral density, and mammogram. You don't have to get a bone mineral density every year. You don't have to get a mammogram every year. No way. Mammogram rate of getting it is based upon what your mammograms are looking like and what your risk factors are. And it does not have to be every year. No way. I'm not giving you a year because some women we don't test them every 5 years or every 10 years. Other women we are testing them every year. And there's a rare woman we're testing every 6 months.
Wow.
Yeah. So I'm not going to go into that right now, but what I'm saying is 24-hour urine in a woman we're treating with compounded bioidentical hormones, we're testing them every year.
Right. And so this question comes up that states, I'm having my labs done tomorrow, which I'm assuming she's already had done. I don't know how she had these labs done, but she says, I know to stop my thyroid medication. However, am I supposed to stop my other hormones as well when I test?
Well, on a 24-hour urine hormone test, and I don't think that's what she's talking about. Absolutely not.
Right.
When you're doing a 24-hour urine hormone test, it's able to see how these hormones are getting into your body real time. So, 24-hour urine hormone test, the criteria are you're taking your hormones religiously and you're not missing doses for a week before and also during the 24-hour urine collection. Thus, we get a reading of how these hormones are doing while you're taking them. That's what we want.
Right.
Blood test is different. And I assert that blood test is not N-O-T, the proper way to test a woman who's you're treating with hormones. We do want the sex hormone binding globulin. That's an important blood test. But 24-hour urine hormone test is how you test a woman that's being treated. Now, thyroid's a different story. We do blood testing for thyroid. And the ritual that I like the best is people are taking their thyroid hormones in the morning. And it's not going to work for us, or at least I don't do it, for you to take the more. We always want women to go in and get blood tests. I say this for everybody. You want to do it right. It's not needed for every test, but you're going to get the best numbers if you fast the midnight before, from midnight till they draw your blood. And that fast does allow you to drink water. In fact, it's great for you to drink water. So you drink all the water you want. The more the merrier, your veins are going to show up better. But nothing, as in zero, from the midnight before. And you go in as for an early morning appointment as you can schedule. I mean zero. We don't want you to have your thyroid medicine, because if you take your thyroid medicine that morning and we do a fasting blood test on you, you're going to get super high levels because you just took it. That's the problem with blood testing and hormones. I love blood testing. I do a ton of blood testing. I always have. People sometimes get staggered with the complexity of the blood test requisitions that I send in there. But I do not want to, if I'm going to do thyroid on there, which I always do, I'm going to want you to not take that thyroid that morning, because we're going to, yes, it's not great. We're measuring really a combination of what your own thyroid gland is putting out plus the thyroid hormone you took 24 hours earlier. That's what we're really looking at. Well, I know how to look at those numbers because I've done it so many times. There's some doctors who are going to say, well, yeah, we want you to draw your blood 4 hours after you took your thyroid hormone. They're going to be looking at a peak there. It's not an exact peak for that exact person, but that's a good way to do it too. But not fasting and then get your blood drawn right away when you're taking thyroid. Remember, I said other hormones we want to evaluate by the 24-hour urine hormone test, all the steroid hormones. We don't want to bother testing a woman who's being treated with hormones. We don't want to test her hormone levels by blood. We want to do it by 24-hour urine hormone test. But thyroid, if a woman is taking thyroid, and so many women do, so many men do as well, I take thyroid. We want you to be fasting from midnight on, water only, nothing else, and not your thyroid meds. So and if we're doing blood glucose, which is very common, or blood insulin, we don't want you to have anything but water. We don't want you to have toothpaste. We're not going to get your best numbers if you have sugar, if you have toothpaste that has a sweetener in there, like sugar. We don't want you to have coffee. That's going to trigger your insulin glucose mechanism to keep your blood, it's going to shoot your blood glucose higher than, we don't want you to have anything but water. So going in the morning, here's the simple thing to remember, no matter what blood test you're doing. Fast from the preceding midnight, water only, and nothing else. No toothpaste, no nothing. No nothing is a medical term. No nothing from the midnight.
No nothing.
No nothing from the midnight before. Do you want me to address those testosterone questions, Carolyn, or you choose?
Yeah, well, yes, thank you. Well, the top one says, please address testosterone free.
It's why I wanted to do that is that's a very relevant question.
Mm-hmm.
The ovaries, for example, are putting out hormones, 4 of them: testosterone, DHEA, 3 estrogens, and progesterone. And these hormones are known as steroid hormones. They're not the only ones. There's other steroid hormones. And these hormones are fat soluble. They're not water soluble. They're actually made out of cholesterol. Very sophisticated biochemical conversion process. Cholesterol, if you remember, is a fat. So when you think of fat-based biochemicals, think of your salad dressing of oil and vinegar.
Shake it up.
The oil floats on top of the vinegar layer. The vinegar is water soluble. You can dilute that vinegar with water, but the oil is going to be floating on top. Well, you can't just pump oil out of the ovary and have it float around the bloodstream. It's going to float around as fat globules, and the blood doesn't do that. The body protects you for the very important things that are fat soluble only, like vitamin A and vitamin D and vitamin K. These are fat soluble only. Well, anything that's fat soluble that's produced in your body, in order to transport it around to all the cells, the body uses a mechanism. So when the ovary secretes these fat soluble steroid hormones, all four of them, it puts them into the bloodstream, and the bloodstream immediately donates these plasma proteins. They're proteins that have an affinity for these fat soluble hormones, and they bind them up. So that's how fat soluble stuff is transported around the blood to all parts of the body. It's carried by carrier proteins. It's bound to carrier proteins. That works. That's how they're transported. And when you measure a total testosterone, for example, that testosterone is bound to it's bound to sex hormone binding globulin. It's a globulin. Maybe you've heard of globulin. It's a big protein. Testosterone is primarily bound in a woman to sex hormone binding globulin. It is in a man as well, and that's how it's transported around. So is estrogen. Estrogen is transported around by sex hormone binding globulin. All these steroid hormones are. They're also bound to other proteins. They're also bound to other serum proteins, even to albumin. Albumin is a protein that's floating around in your bloodstream and mine. So thyroid is bound to another serum protein, primarily called thyroid binding globulin. But these things, as specific as they are, they're also general. So, thyroid can even bind to sex hormone binding globulin. But the moral of the story is these things are bound to serum proteins. Almost all of them. So when you deal with testosterone, most of it's bound, but some of it is able to float freely in the blood.
Is this a protective measure?
Well, the reason that's bound is so that you can transport this stuff around in the blood, which is not fat, it's liquid.
Mm-hmm.
It's water. Serum has got a lot of water in it. Now you're referring to another quality, another trait of these serum proteins. But before I go there, the original question is what's free testosterone and what's total testosterone? Well, free testosterone is the amount that's not bound, and it's minuscule compared to the bound testosterone. And the same is true as estrogen. The vast majority of it is bound up to serum proteins, and some of it is floating freely. It's not bound. And the same is true of progesterone, and the same is true of cortisol, and the same is true as thyroid.
But not dangerous.
Not dangerous at all. In fact, it's the free portion that actually is the biologically active portion.
Mm-hmm.
So when we measure testosterone in a woman, which is good to go if you're not treating her, you measure free testosterone and bound testosterone. You measure free estrogen in a young woman that you're not treating. That's valuable. That's going to tell you something. That's in a young woman who's not being treated. Once you start treating, you want to use 24 urines for the ovarian hormones. So when we measure in a 24-hour urine testosterone, we're actually measuring free testosterone. Same with estradiol, we're measuring free estradiol, we're measuring free estrone. Now that final thing that you were saying is, aren't they protective? Yeah, let me give you an example. You've got a young woman, 20 years old, she's at the absolute maximum amount of her whole life in the production of testosterone or the production of estradiol or estriol. She's at the absolute amount. And her ovaries are putting this into the bloodstream, and the majority of the testosterone, the estriol, the estradiol is bound to serum proteins. Sex hormone binding globulin is one of the most common ones. And then you give that young woman a birth control pill. You're giving a young woman who's at the peak of her estradiol output a pill that contains additional estradiol. Well, her body registers that. And it goes, what the heck's going on here? You're already at a maximum amount of estradiol. We don't want you to be dealing with too much estradiol. So no problem. We'll just increase our production of sex hormone binding globulin, and we'll bind up that extra amount so it won't be active, so you won't have biologically excessive amount of estradiol. We'll just bind it up. We'll just produce an extra sex hormone binding globulin. So a young woman who's given a birth control pill, very often her sex hormone binding globulin level increases. Oh, inconvenient truth. The thing that in a young woman that binds best to sex hormone binding globulin is testosterone. So you give some young women that birth control pill and they lose their libido because they produce some extra sex hormone binding globulin and it bound up their testosterone. And that's what you're referring to, the protective function. Put out too much, take excessive amount, your body's going to protect you from an excessive amount of estradiol in a birth control pill. It's going to bind it up. It's going to increase the sex hormone binding globulin, but it's also going to bind up your testosterone. So you can lose your libido. So there's a certain number of women who go on the birth control pill, they get diminished libido. That's the protective effect. And lo and behold,
it is not so. It cannot be.
it cannot be time.
I gotta book you out for like a 12-hour day.
Yeah, sure.
Yeah, sure. I've seen it happen, sort of. Dr. Rosensweet, thank you so much, always, for answering these questions. Thank you, ladies, for coming up and asking them. I have other ones to get to, and I will. And we will answer them. And I'm wishing everybody a wonderful, wonderful day. Belated Happy Easter. Happy Passover. Enjoy. And I just hope everybody has a really, really, really nice, nice day. And we will see you in a couple of days. Yeah?
We will. Thank you, Carolyn. Thank you, everybody. Good to see you all.
Oh, it's always good to see everybody. And we did it.
Okay. Thanks, Carolyn.
And thank you, Dr.
Thursday morning.
You have a wonderful day, and everybody, too. We will see you in a couple of days.
All righty. Bye-bye now.